And I've got some good guests on the line. I'm waiting. There's a couple quick reports I'll give you from various folks that I've talked to, whether our friends in Singapore or in Melbourne, for example. It's interesting because it's almost the conversation with the people. And well, actually, I better give us start with Craig. Want to give the usual caveats, Craig?
Yeah, sure will. Thanks again for everyone for joining us. This is our Friday 10:30 Central call for the Eagles Web Group. Remember that the meeting, although is closed initially for our discussions, we do post it and it's in a public area for people to review, and we want to share that with lots of folks. So just be aware of that regarding your comments and discussions with that. And as always, we're appreciative of folks sharing their time and talents. One reminder is our Eagles website. We try to keep that updated. If there are things that you think need to be posted that are not, please let us know. And that's probably best to either come through myself or Julian. And then as well, we have the forum. If you haven't logged in and signed up or requested access for that from the useagles.org website, please do that. We don't want to change horses in midstream, but we do have the forum that may allow for a little easier cataloging of our discussion points and topics when you go back and try to find things. So again, we just encourage its use as well. And we're so thankful for this group in again, sharing pieces from the support group component. And with that, Paul, it's your show. Go for it.
Okay, so as I put on the last working agenda that we had was that welcome back, my friends, to the show that never ends. By the way, just as an FYI, that was I took that picture on the entrance to the Hard Rock. We were supposed to have our meeting this June, etc. And so it was kind of cool that they did that for us. So one thing I want to say is that I'm going to make some introductions today. But I do want to make sure, because there's some people, this will go public and people may not know who we are. So the majority of the people on this call, for those who are not familiar with it, are going to be mostly the jurisdictional medical directors of the largest cities across the United States, and some of our friends in Europe, and the Australians can't join us, and the people in the Pacific Rim, because it's the middle of the night for them, but some have actually said they're going to come in. We do have people like Stefan Polacek on the phone from Berlin with us today, Mike Osterholm, the director of the Center for Infectious Disease Reporting and Policy, and really grateful to have you on, Mike, largely because I just see you every 30 seconds on everything else like MSNBC or I guess this morning, I think I heard you were on CNN. I don't know who it is, but you're always on something. So I don't know when you sleep, but do take a bathroom break occasionally if you don't mind. All right, so with that, remember again that we will, as we move through this thing, that I really would love to know ahead of time if anybody has considerations or would like to make things, because if I leave you out today, I don't mean to do so. It's just that I didn't see that you were trying to get on them. So I'm going to try to juggle this as we go through it. All right, hey, John Jew, are you there today?
Yes, I am, Paul. Can you hear me?
Yes, good. Okay. What I wanted to do, just as a gambit for today, is just talk about a little bit more, drill down a little bit more on some of the presentations that we're seeing clinically, at least in the United States, and it sounds like it's maybe similar to in other countries as well. And one person that may be able to react to that would be Mike Osterholm, to tell me if we're totally off base or we're on track here. But the general principle is that.
Oh, I'm on. Just got on.
Yeah, okay, got it. I understand. I'm just gonna go through a description about what we think we're seeing clinically, or the kind of the syndrome, so to speak, or the whole clinical course. And then please, if you're seeing something different, you're always so smart about this, and you've given me great advice over the years. So I just wanted to make sure we're on target. But as I call it, it's the un-United States of Chimeria. It's somewhat chameleon and chimeric in terms of the presentations early on. So as I've mentioned before, the classic presentations have been described as the shortness of breath, cough, and fever have probably been related to people going into the hospital, and that becomes a chief complaint, and therefore that's their presentation, and that's what's been generally reported. Looking back, a lot of those folks actually say, and I think about it now, I was very lethargic and didn't even feel like getting up that morning, and they may have had a prodrome, or for lack of a better word, or a low symptom phase for the first week or so. And so it may be classically 4 to 5 days, but it also could be a range of 2 to 11 days after exposure when they get their first symptom. And it has this kind of a bimodal phase where you're actually feeling, just terrible, or you feel the quote unquote flu-like syndrome. But the flu-like symptoms are kind of, again, chimeric or different across individuals. And some people have just GI cramping and maybe a little diarrhea plus or minus myalgias. Or one of the things they're reporting out of France and the UK Society of Rhinology is giving it some credence, at least to pay attention to it, is that some people are just presenting with anosmia alone. In other words, lack of smell or not smelling well, or even taste problems, and especially in young people. But it usually is usually a mild disease, and so they're just thinking that's all it is, but later they turn out to be positive. So we don't know, they just happen to turn out positive because it spreads around and people are asymptomatic. But there is some basis for it, since other coronaviruses can cause this and other disease processes that can do this. So one of the things that we think is interesting, besides like low-grade fever swings, lethargy, fatigue, and nausea and anorexia during that period, is something that John described to me as silent hypoxemia. And that's actually what we're seeing. In fact, people get into the hospital, sometimes they can have positive x-rays and not have any kind of shortness of breath at all. It's behaving more like an high altitude sickness, where you're, hypoxemic, but don't even know it because you're not feeling short of breath. You just have all these kind of bizarre kind of, chameleon-like symptomatology. So that's kind of how I look at it. I think of it somewhat like a high altitude sickness period. So they may come in and be, have this picture with a cough and so on, and not even feel short of breath, and yet they're having the bilateral infiltrates. Sometimes, by the way, it will come up with a right lower lobe infiltrate and then go on. It depends, like testing, it depends on when you sample them. But if they all will have hypoxemia generally and so the pulse ox is a great tool. The reason why I'm bringing this up is that might be a very nice screening tool for us as well, is to make sure that we use our pulse oximeters. I have one, I had one right around my neck here a second ago, but I carry little finger pulse oximeter with all along, as well as a temperature just for myself, let alone other people, to see how they're doing. So I think that those are the main things is that we're seeing. And there's also probably some silent cardiac changes. Some people may have like a mild myocarditis and we don't pick up on it till later on. So just things to think about as we are going out there. And by the way, at the end of that, say, week or 2 weeks or whatever it might be for the individuals, there is a period of time where they may then get shortness of breath and cough and feel bad, and then maybe abruptly get better, or that's where they start going downhill, and they may go downhill rapidly, especially at day 9 or 10. Before you know it, they end up on ventilators, if not, at least a lot of shortness of breath and severe hypoxemia for a while. Hey, John, would you add anything else to that, what I've just said?
No, I think you got everything correctly. The only other issue is sometimes the x-ray is negative and their CT is positive here as well. And finally, some jurisdictions who are sending patients home with the pulse oximeter and say, come back if it's low. That's the only thing I would add.
Okay, got it. Mike Osterholm, anything you would add to what we're saying? Are you hearing the same thing worldwide, or at least in the United States? Let's start there.
I think that's what we're hearing more in the United States. One of the things we're seeing, though, is increased frequency of illness in younger adults and children.
Right.
And more so than has been seen in Asia and to a certain degree even in Europe. So that's been somewhat of a surprise to see. I think this morning, my understanding that there are, throughout the United States, about 27 or 28 kids on vents with this.
When you say kids, what age group are you talking about? Are you talking
I'm talking less than 18.
Okay. So, but
we're trying to confirm that, but it appears that there is an increased occurrence of serious illness in young adults and kids. I remind everyone there hasn't been a death yet. Anyone in Korea under 30. China's only had a handful. So this picture just seems to be more severe in kids, and these are all confirmed cases.
But let me ask you this, if I just want to make sure, because we say less than 18, but maybe those are young adults, they're 11 or 12 or whatever or more. Are we seeing in the 5 or 6 year old age group?
I don't have any data on that. That's the best I have. I'm still trying to get more information. I was hoping to have it actually for you today, but we're still trying to get it.
This is Jim Augustine. It has been, these are 14, 15, 17-year-olds that have died. That I just read.
Yeah, the ones that have died, yeah.
Michael.
Okay, that's good, Jim. Thank you very much. So actually, that's been very helpful. And then while I got on the phone.
Hey, Paul. Hey, Paul.
Yes.
I am working my way through Mike Osterholm's book, The Deadliest Enemy. I just got it a few days ago, and it was 2017 published.
Okay.
And it's an astonishing revelation of the lack of planning we've had around the world for this and how it was predicted. So kudos to Mike for an astonishing read. It's also very readable. And I just want to
Thank you.
that up.
Well, again, I remember back years ago, just, talking with Mike, and a lot of the presentations I've given where I was even talking about how this would affect world markets all came out of the discussions with him. And there's been some really good work done on this previously by a lot of good organizations. So in some respects, it doesn't surprise us. But, Mike, a classic question comes in. What's your read now on, is there going to be resurgence of this? How long do you think this will last with the current way we're approaching this? And
yeah, well, I think, again, first of all, let me say I don't think we have any data to support seasonality or not. I remind everyone that if you look at the other coronaviruses, if you look at the cold-causing coronaviruses, they clearly do recycle more seasonally. If you look at SARS and MERS, SARS was a situation where we just picked it up in early February of 2003. It took us literally several months to try to figure out that these people were not really that infectious till day 5 or 6. By the time we figured that out, we got the palm civets out of the Guangdong market, so we didn't keep getting pinged. And by early June, it ended. A lot of people interpreted that to mean summer did it. It wasn't. If this had happened, I think, in October, we would have finished it off in February or March. If you look at MERS, that transmits year-round. I remember standing outside of a hospital in Abu Dhabi, and it was 110 degrees, and we had one hell of an outbreak going on at the time. So, that doesn't lend itself to seasonality. If you look at influenza, I always remind people why we all are focused on seasonal flu based on where we live. We have widespread transmission year-round in the tropics. We've never understood that. If you look at the last 10 influenza pandemics, 2 started in the winter, 3 started in the spring, 2 started in the summer, 3 started in the fall. And if you look, the big wave was always about 6 months after the start, 2009, mid-March to late March. The big wave was in between mid-September and mid-October in North America when it was still warm. So one is don't count on seasonality. We don't know. Number 2, this is a blue state disease right now. People are obviously focused on that. It's in the big cities, etc., but it's coming to the red states. I have no doubt about that. It'll get into the rural areas. We see this with seasonal flu often, where you basically start out the season in larger metropolitan areas with more robust transmission, but by the end of the flu season, small-town hospitals, small-town long-term care facilities, all have been hit hard. So I have every reason to believe that this is going to take time, but it's going to spread out through all these areas. Now that the president's going to recommend this afternoon that this be a county-by-county decision on what to do based on the surveillance for the area, this is frankly not going to work for the life of me. I've got a piece coming out in the New York Times later today. We've been doing a major investigation on looking at testing, and testing in the United States, for that matter, in the world, is about to implode. We're running out of reagents. We're sucking reagents down the size of a tunnel, and all we got is a garden hose to restore the reagents. And so you're going to see this build-up with everybody talking about testing, and tests are going to really, really come in short supply within 3 weeks. So now we're going to be back to syndromic surveillance, et cetera. We won't be able to distinguish who necessarily has infection or not. It's going to be very hard doing clinical follow-up, and I think that's going to be a challenge for us trying to understand. So those, I think, are the major issues. The PPE issue is huge. Let me just make one comment, and if I sound strident on this, I surely don't mean to be, but this is a bunch of BS about the whole issue around the Defense Production Act. It's meaningless. It is meaningless. I'm not pro or con what the government administration is doing. I've had discussions with the leading car manufacturer, CEOs of the country in the last week. They don't make anything. They build things, assemble things from things that other people make. And when you look at just one mechanical ventilator, the 176 different parts that come from 14 different countries, nobody who was previously making engine blocks can suddenly overnight start making mechanical ventilators. No, N95s are a science. I mean, that poured matrix, that material on your face is poured. It's huge. Nobody can just start making these things. And the industries that are involved, 3Ms, the Honeywells, they've been working 24/7 since January to try to keep up. And so a lot of people have this sense that there's this, the cavalry is coming with all these new things. And frankly, it would, I don't want to belabor it, but after World War II or with Pearl Harbor, it took us 3.5 years to still build up the Pacific Fleet. From that moment, we couldn't do it overnight. We will not bring on any new PPE of any substantial nature through the duration of the rest of this year. And so, as a former Secretary of Defense once said, when you go to war, you can't go with what you want, you got to go with what you got. Yeah. And I think we're going to have major crisis on PPE. So Mike, I'll leave it at that.
Yeah, so Mike, I need to cut you off because I got a few people I have to get on the line before they have to leave, and that's what I'll switch gears. I'm going to come back later to the concept of positive tests.
Paul, I have to leave right now too, so I just wanted to share that. I'm sorry. Okay, I've got to go.
Okay, that's fine. So far, so good for what we're saying, right? So I just want to make sure. Okay, good. Thank you for
it.
Okay.
Thanks.
All right, so let me switch on real quickly to Sandy Schneider, who's here from ACEP. As I introduced her previously to you, she is been a person who's been chair of and president of every organization, and she is now the, I think the official title is Associate Executive Director at ACEP, and the highest ranking physician in the organization at the headquarters level. And she's leading the charge from that end. And so, Sandy, do you have any particular things that you'd like to add in, or we should know about, or be aware of, or things we can do for you?
Right. So just to bring you up to date, I've been doing a lot of liaisoning with other organizations. I've been talking with the NIH, urgent care. By the way, just as an aside, urgent care is dying because they have no patients. And so their docs are actually, some of those urgent cares are probably going to close. Talking with nephrology, et cetera. The one that is important for you to know, the American College of Cardiology is going to probably be asking for suspension of pre-hospital activation with ST elevation, and particularly in those communities where COVID is pretty common. Based on the Italian experience and some of the other experiences they've had in Washington State, the number of activations goes up dramatically when this disease is very common, and the number of clean casts is extremely high in patients who are COVID positive, and since they represent the majority now in those communities, they're saying that probably the only patients that should get a cath are those with wall motion abnormalities where that's available. And if not, back to the old days. The reason for this is they're seeing just a huge number of people who look like they're having STEMIs, having ST elevations from pericarditis, having ST elevations from myocarditis, looks like a STEMI, but it's not a STEMI. So I think this is going to be a change for you guys. It's certainly going to be a change for us. Their document is coming out, I've been told, on Tuesday. We do have writing people. We have a MOMA2 on that group, so I'm pretty comfortable that he's going to make some very good decisions. That's not the only thing, by the way, they're talking about. They're talking about treatment, etc. ACEP will be coming out in the next week or so with best practice guidelines. We welcome you guys to participate in that I hope you will when we fill out. To just echo what was just said, our members are just saying PPE, PPE, PPE. We're working on it, we're trying, but you heard the bad news. It probably ain't going to happen. We're trying the best we can. The CDC has been in just within this group, I think, a little stubborn, a little late to the game. ACEP has been calling, as well as some other groups, for universal precautions, especially in those communities where COVID is common. We have to assume, just as we did in the HIV days, that everyone has it. There's a bunch of other stuff here on my page, but nothing that's important except for the fact that we are hearing from our rural hospitals that EMS in the rural and small towns is suffering badly. I know
Yeah.
you guys are suffering badly, but in the rural communities and the small towns where these are largely volunteer, where their medical director may be somebody who may or may not have emergency medicine or have some background like you guys do. I don't know what can be done about that, but I throw it open for you guys to think about, because I think if, as this plays out in the rural areas, if they're already having trouble when it actually hits the rural area, I very much fear for the EMS system in some of these communities.
And that's a little bit what Mike was alluding to before, that you're going to start seeing, as he said it, in the red states along those lines. But interesting. All right.
If there's anything ACEP can do for you guys, please let me know. I'm not brilliant. I don't know everything in your lives. So it's sschneider@acep.org, sschneider@acep.org. Just reach out and tell me if it's a crazy idea. I'll just delete it. If it's good, we'll do it.
Thanks a lot. And Sandy, if you can, just stay online with us and hear what's going on, because we're going to start talking to people not only in Europe, but also across the United States and specific areas. And so many of you should be prepared. Some of the people I'm going to be calling on today will be the people from everywhere from Atlanta and Colorado Springs and so on. And also some of the cities will hopefully get some follow-up from Seattle and New York, if those guys get on. And then also, hopefully I want to hear from Joelle and Mark, et cetera, about some things. Then we're going to talk about no load and triage policies. We can get to it all. And then maybe get Jim Augustine to give us the latest on our librarian, so to speak, reports on the latest Eagle surveys as we get through it. Let me start off first about giving you a little bit of a report worldwide. The Australians, this is like 3 o'clock in the morning for them, but I made contact with almost everybody in the large cities there. And they're almost akin to where we are and what we're seeing, for example, in Broward County, Florida, namely that the emergency departments and the EMS system seem to have had a slight decrease in volumes that have gone down, which probably makes sense. People are less apt to want to come in and get sick at a hospital, and they're less apt to maybe call, because they're supposed to say if they have minor stuff, stay home. It's all elective kind of mentality right now. But what's interesting over the last week or two, and this is the same thing, the reporting in Melbourne, is that there seems to be a growing increase now of people with what you would call what they call them a level C call, or those with their more serious complaints are coming in, and they're starting to have that accelerate, and they foresee that it's going to be a lot worse. In 2 weeks, they feel like most of their ICUs will be completely full based on what's happening right now. And they think even by April 10th, their emergency departments will be full. So they're kind of akin to where we're at. It's not too far off. Same thing happening over in Perth. And I hadn't got through the Sydney people. Stefan, you're over in Berlin. What's happening over there, if you don't mind? Can you get on, Stefan Polacek from Berlin, our Eagle there?
Yeah, hello everybody, and it's great to see you all together, still sitting on the desk and not on the front. What's happened in Europe? I think you are informed about the situation in Italy and in Spain. It must be very, very dramatic there. They have about 500-600 days dead persons a day, and it's nowadays it's hardly to get contact with the colleagues there by personal, because they are very, very hard working there. So for Germany and for Berlin, when I take the picture of the tsunami, we see that the sea is going away every day. So we have empty hospitals, low numbers of EMS calls, because we have a nearly complete shutdown in the city. And we are trying to build our towers for the moment when the wave is coming. So we are trying to make our concepts at the moment. We are working at an ambulatory concept with the EMS, with testing at home. We are starting tomorrow a concept with putting paramedics on special cars. And it's not a German concept. Perhaps you know it from for example, UK EMS, to send an first responder with an advanced paramedic. It's absolutely new for us. And we are working at the moment at a concept for inter-hospital transfer. We have structured in Berlin a system of connecting all our hospitals. So we have the Charité, the big university hospital, who is responsible for all the high-end intensive care with ECMO, and we make level 2 hospitals, establish a system like in the trauma care or something like this with level 1, level 2, level 3. And that's just on paper, on PowerPoint, and on video conferences at the moment. At the moment, we have in Berlin, we have about 2,000 cases, about 40 people on ICU, and 10 deaths at the moment. So it's still quiet, but we are in the conceptual phase at the moment.
Well, let me ask you about the shutdown that you've done. Now, for example, around our parts, even when they've had shelter in place, so to speak, and same thing in Melbourne, I heard last night, but people still can go to grocery stores, they can go to markets, they can go to pharmacies and select places, they can pick up food at a restaurant. Are you allowing that? Because it sounds like you're doing fairly well compared to us. How tight is the controls there of people getting out?
So we make it stepwise, and it was a lot of work the last weeks to convince our politicians about the steps. But at the moment, for Germany at all, and also for Berlin, we have no restaurants, no bars open. We have no shops open with except of groceries, pharmacists, and some more. No hairdressers, only real medical stuff. So offices of general practitioners, hospitals, and so on. Work is quite normal. So we had not a shutdown yet from normal companies. They already did this in Spain and in Italy, so they only work in system relevant groups. But in Berlin, we have still places for work, but no restaurants, no shops, and it's not allowed to go outside for leisure. You can walk outside, you can make sports in the parks, for example, but you are not allowed to sit there.
Okay.
And you are only allowed to get contact with people who live in your own home.
Got it. All right. And it sounds like they're doing the same thing in Brussels, and they're doing very well. And so it may be, again, the sociological issues. I thought maybe for a while it could be, a different strain hitting Italy or some of the other places, or UK's getting hit, but it probably has to do with the social distancing issues, quite frankly. And so that's very interesting. So thanks for the report. Anything else you want to add in before we move on to the other cities? Okay, if not, let me go ahead. And now, Jean-Louis, by any chance, I don't know if you got on the line. You were going to try to. I don't know if I see you or hear you on the line here. But let's move on. I want to talk about what's happening in some of the cities. For example, Meg and Emily, hopefully you're on from New Orleans. And then Mark is supposed to be able to get on the phone here in just a minute or two from San Jose. And I know that you guys have had a significant number of exposures to your own people. And I just want to know how many people were positive, how many people you're just basically putting in quarantine, and what's the impact been so far, or what do you fear the impact is going to be on your staffing, et cetera. So let's start off with, Emily and or Meg, if you're on the line. Emily Nichols or Meg Marino. Are you there?
Hi. Yeah. Hi. Good morning. I think we're both on the line.
Yes.
Okay.
So this is Emily. Meg, I'll start and then I'll let you fill in. So yes, Paul, thank you for having us. As you said, New Orleans is an epicenter. We're up at rates, matching New York City. We've been fortunate to have a lot of testing being done with some, with supplies coming from HHS. So we are getting a better understanding of the illness, but as everyone said, eventually we're going to go back to where we started, I suspect, of just presuming that everyone has it and not actually being able to count them one by one. Meg can speak more particularly on the number of our staff that have been exposed, but I think it's about close to 80% of our crew at this point. Luckily, we about 75% of them were wearing appropriate levels of PPE at the time of their exposure. And it seems as though our percentage of employees who are becoming symptomatic do match kind of that other 25%. But Meg, if you want to talk on that further, I'll let you go ahead.
So we've had 4 employees who have tested positive, and So now before we were presuming that everyone had been exposed, but now we're really presuming that everyone's been exposed just because they've all had contact with those 4 employees. We have 30 employees who are in isolation at home with symptoms. And we have about 80% of our workforce has been exposed to cared for a positive patient. So we're slowly, as some testing is coming back as negative and as their symptoms are resolving, we're allowing some of our employees to go back into service after 3 days without symptoms. But it's definitely taken a big toll on our workforce.
Okay. And it sounds like your hospitals are also getting hammered pretty well from the reports we're getting from there. And some of the people have given us the clinical reports and they're seeing the same things we just discussed. So just good on you there. And thank you for what you're doing. So this is like not your first rodeo, but it's still it's a different kind of rodeo. Let's move on to Mark Gautreaux if he's there. Mark, have you shown up yet? I don't know. You're on another conference call, supposedly. Are you back in?
I am back in. How are you doing?
Good. Fantastic. So good to see you, man. And so tell me about San Jose. What's happening out in San Jose?
So earlier this month, we had a situation pop up where we were notified by the CDC that one of our firefighters had been admitted to a hospital in his hometown in Southern California and was COVID positive. He had thought he had a cold and had worked with symptoms for 4 48-hour shifts. And in the short run, we had 85 exposures in a two-company dormitory style station. Roughly 15% of those contacts ended up testing positive themselves. Initially, we actually had to pull up to about 100 firefighters on quarantine for 14 days when we were quarantining close contacts, high-risk contacts. That's as more firefighters became symptomatic, we hit a period of time on a Friday night a few weeks ago when we were actually shutting down companies and running into issues where we couldn't staff all the companies in the department. We quickly discussed with public health a strategy where asymptomatic high-risk exposures could then actually work until they were symptomatic. And that's the policy we've been working on since. We're a pretty steady state right now. We continue to have some firefighters become symptomatic. The situation in Santa Clara County is per capita probably the worst in the state right now. And most of that is actually focused in the city of San Jose. The northern part of the county up where Stanford University is actually is not seeing a huge amount of activity. We are at Stanford, we're actually building new ICUs, converting old wards into ICUs and preparing for a surge, but we're now expecting that would come as overflow from San Jose.
Okay. And I don't know if either Peter Antevi or Randy Katz or Ken's on board. We're going to talk about some alternatives about 2 issues is that of looking at what we're going to use for potential ICUs, et cetera. We'll see if we get there. All right. Anything else then, Mark? Thank you for what you're going through. Geez. And then you're just getting ready to get hit, aren't you? So not quite.
We are. And one of the other strategies in the meeting I was on just now is we have opened up a bunch of testing sites through Stanford. And one of our executive level decisions was to prioritize testing for the first responder community so that the turnaround time could be shortened compared to the general population, with the idea that those folks need to get back to work if they have a negative test. I can tell you that out of the thousands of tests we've done at Stanford, roughly 7% are coming up positive. So it's a very low positive rate.
Well, we're going to talk about that a little bit later, or hopefully if we have some time, I'm going to have John address that a little bit. The issue about false negatives, which I think is a lot higher than we think, and we're going to talk later about antibody testing, which may actually come available fairly soon. And I think that's the thing I'd really like to see, because you actually may start having positive antibodies within a week or two of of your exposure, and that may help us a lot versus some of these particular issues with the testing. So I'm a little wary sometimes about people who have a negative test, to just let you know, especially if the clinical thing looks differently. So that brings up thing. Ron Roth he just joined us from Pittsburgh, but I was just saying he was having everybody self-test themselves with temperatures every day at the stations. But one of the things I wanted to run by you, Ron, was that we were talking about that there may be a certain degree of what we call silent hypoxemia going on. So we're actually hopefully adding in, finger pulse oximeters or, whatever it may be to sort of to look for that as another kind of a cool screening test. The other thing is the lack of smell may be a very odd one, especially in younger people that may be there. Just, anything else you would add from your end in Pittsburgh, Ron?
We're starting to see diarrhea as one of the
Yes.
presenting symptoms, and I know Seattle had that, and so we're seeing that right now. So far, so good. We're waiting. We're in the lull before the storm, I believe, because we're probably a week behind everyone else.
Yeah. Okay. So one of the things that you may have missed, and I was going to just do a quick digression over here, is that Joelle, who takes care of the pediatric population, has been very good about neonates in particular as being different resuscitation-wise, is probably pointing out that she wouldn't be surprised to see it in the very young populations. Joelle, do you want to comment on that real quickly?
Yeah, sorry, it took me a while to unmute. Can you hear me okay?
Absolutely. Cool hat.
So they're still children. They still have, the under 2-year-olds, especially the ones that are preemie that have increased complexities. They've got the smaller airways, they've got the smaller lungs. They're still going to be prone to bronchiolitis. This is a severe respiratory illness. It's still going to affect the young. When you look at the literature coming out of China, while pediatrics have great outcomes, when you break it into age stratification, the very young still, this is a severe respiratory illness, they still get the severe bronchiolitis respiratory failure. So we have to look out in the pediatric population, those very young, and just be aware of that as well. It's just like all the other respiratory viruses.
Right. And hey, Joe Holly, are you on the line with us from Memphis? And we're going to come back to you in San Diego later, Joel, just so you know. Okay. Okay.
Yeah, this is Joe.
Yep. So anyways, I saw you said on the chat that you agreed with her. Is there a reason why you were bringing that up? Are you seeing things in Memphis?
We have had a couple of admissions to our pediatric hospital that have testing underway. I hope to have results back today on that.
Okay.
And so I think we are beginning to see some of that as well.
Okay, got it. So, and I don't know if anybody else has any other speculations of why we're seeing more of it here than the reporting in China, or is it just the reporting issue, as you know, has always been a somewhat of a issue for us all.
Can I add one comment?
Sure, go ahead, please.
So the taking all the kids out of school, and this was brought up at a countywide meeting yesterday, we seem to have decreased respiratory illnesses just in general, like people aren't coming to the hospital. All of our volumes are down. So our children's hospital has actually offered to start seeing adult patients up to 26. And that was based off of what they were doing in Seattle. So if you have highly involved children's hospitals, they might be willing to also take the younger adults.
Interesting. Okay.
Ours is offered to go up to 18 where they used to do 14.
Is that here in Fort Worth? Is that right?
It's there.
Yep. Okay, good. Hey, so let me now switch over real quickly to sort of to get some reports on, and we're going to talk later hopefully about some dispatch issues and all that. And I think I've covered a couple of the cities I wanted to catch, and we did talk about the rural area issue. I wanted to make sure we caught that one. But let me move into, like, Jim Augustine, if you're there, if you could tell me if there's anything percolating up with the IAFF, IAFC, and also give us maybe a quick couple of reports that we've done some Eagles surveys lately, and you're our librarian. Can you tell us about what's happening in that arena, and what some of the findings were so far for those of us who didn't know it or visitors to the call?
Yep, thank you. IAFF, big concern is about the protection of workers and the N95 requirement. NIOSH is about to publish a report. Well, they published a report that said, N95 at a minimum, and they seem to be completely disconnected from the real world where N95s are not available. So your firefighters are going to hear from their IAFF that N95s are a minimum. and a lot of agencies are moving to no fire engine response unless Delta or Echo calls, or a select group of Delta Echo calls. So I want everybody to be aware what's going through IAFF. IAFC is very important in the supply chain issue and in keeping fire EMS providers at a higher tier in terms of available COVID tests. It has been a problem, and in a lot of states, the fire EMS and other public safety responders are moved down in the tiering, and in some cases, they're only at tier 3 in terms of priority. Well, that makes a big difference if you have people who need tests to return to work quicker than a 14-day no test strategy. So making you aware that's what your fire chiefs are going to be involved in. The fire chiefs are also being told that some of the problem with our PPE shortage is logistics, not manufacturing issues. So like we discussed earlier, we can't move manufacturing necessarily on a dime, but if there's supplies available somewhere and it's a logistics issue, the federal government should be addressing that much more quickly than they are. Our surveys right now, hand sanitizer, what a great discussion, and thanks. And we have prodded a couple people who responded to me privately that they would look at their local distilleries, and what a great use of resources. So thanks. That originally came from Kim in Albuquerque about their local distillery, and that information was really well used. We have a current survey. I had to put 2 out back to back.
Jim, let me interrupt you. Mark, you guys had, Mark Gautreaux, if you can, you guys actually found like the best practices there in terms of hand sanitizer, right? Tell us about that.
Yeah, so what I heard was you take some aloe and a bottle of vodka, and then you drink the vodka until you really don't care anymore.
All right. Thank you for that contribution.
Yeah, but what do you do with the aloe then?
That's good. Well,
Paul, let me comment about that. This hand sanitizer thing is a big problem. About a third to a half of the Eagles that responded said that they're having a world of hurt. I know in Georgia, we're having a real hard time finding the product. WHO has put out a document talking about how to make your own and so forth, and that's available at WHO.
Yeah, but it's still hard to get things like the alcohol, and that's the reason why the vodka may not be such a bad substitute in some respects, literally, especially if you get 120 proof, right? Hey, by the way, Ray, this is really a nice glimpse into your Mockingbird Station home, and I see way in the back over your left shoulder those bottles of wine up there above the refrigerator. Very cool.
Yeah, those are all first growth Bordeaux. Paul, eat your heart out.
Yeah.
Hey, listen, back to the hand sanitizer for 10 seconds.
Yes.
You have to have a high percentage of ethanol. The only one really around that would do, which is 70%, 60 to 70%, is the Everclear brand. A 750 bottle would be diluted with aloe to a quart and then could be dispensed. That's in the WHO. Michael Sayre also had a nice picture he put out today, or to me anyway, because he couldn't get to the group, showing how they're making it there.
Okay. A couple things that, anything else besides the hand sanitizer? I think we covered that, but there's obviously an issue in many cities. Some people are saying we're fine, but there are still people that are hurting pretty badly, right, Jim?
Yes. Yeah, there are people hurting, and some of them are peroxide-based solutions also. And then 2 surveys quickly in your box. One of you, Megan Gussick, needs to know if you have a jail and what you're doing at your jail if there's outbreaks. And a second is from Indianapolis, asking very quickly for those of you who have third service EMS, if you have an EMS person who is COVID positive and they've been in the fire station, how you're handling the exchange of information without getting into HIPAA issues. Nonetheless, those are 2 different agencies housed in the same station. It's become an issue for some of you. Would you share your best practice in relation to that?
And then the converse to that is I'm hearing some questions that just came up. For example, what if you got a COVID negative test, which I'm concerned about because I think there's a lot of false negatives, and yet they're symptomatic. How are you handling that? So we just pitch that out to the group. I don't know how to control that one, but I'd love to hear from anybody who thinks they have a pretty good handle on what to do here. So let's start with the question about, do you test asymptomatic people? And number one, and number two, because Libby Char's trying to ask that from Hawaii. That'll be the first question I have to the group is, do you test asymptomatic people, period? And then two, do you, if you have someone who's positive to the station, like you just heard, what do you do with everybody else? And then the third thing is, what if someone's symptomatic and yet, but we don't know what symptomatic is nowadays because it's not quite clear, and yet they test negative. So, all right, first of all, let's start with that first question. Are you testing asymptomatic people? Anybody doing that?
Yeah, we are not. And we're pretty fierce about that. We're not even at Stanford, we're not testing asymptomatic healthcare workers.
Yep.
Meeting some resistance from some of the physicians, especially in the surgical specialties. But we have that same concern about false negatives. And then the other concern we have is if you get a negative test and then develop symptoms, I mean, are people getting tested every day now? We don't have the testing capacity to be doing that right now.
Right. Anybody else have a disagreement with that general response? Or anything to add on?
Paul, we are moving away from testing anyone that's asymptomatic.
Is that Ed Rock? Sorry.
Yeah, sorry about that. Yep, we are not testing asymptomatic providers.
Okay, so that's a good point. And before I move on, Ed, because I know your time is difficult. So Ed Rock is the medical director, nationally or internationally, you want to say, for GMR, also known as AMR. And what are the let me go ahead and digress from our previous question. And I just want to be able to capture your time that you're on the line, Ed. What are the things you're facing and what are the concerns that you have, since you have people that also do inter-hospital transports and so on, let alone, staffing, various things? I would like to know that. And by the way, there was a very nice paper out of Singapore about their policies and their approach to inter-hospital transfers, in particular in Singapore, that was published in Critical Care about several days ago. And I think I sent it over to Craig Manifold. We'll try to put it on the website, but that's just an FYI. But let's go ahead, Ed, what's happening on your end while I got you on the line?
Just a quick kind of summary of things that we're struggling with. So interestingly, as has been reported everywhere, we normally do about 15,000 trips per day. That's down about 25%. And looking at our data, there appears to be a significant drop in the trauma volume, which obviously would be expected with social distancing and with folks not being out in the environment. Of note, if you look at ILI, a defined field for confirmed COVID, or PUI, depending on our medical record, the indicators nationwide, 18% of our volume is related now to this particular event. So we have 460 total providers nationwide who are under some sort of restriction or quarantine. We actually have 21 individuals who are COVID positive. None are hospitalized at this point. We expect a FEMA activation today. There are several states that are going to activate that particular piece. We are screening now all of our providers that go into 911 communication centers, the fear being that a symptomatic communications officer that goes in could infect and shut down a 911 component. We are okay on our PPE from day to day, but just as concerned as everyone else. Just as a side note, we ordered 125% of our normal peacetime usage in January. We've used that up, so we continue to do everything we can to implement the reuse and continued use policies. We're looking now at face shields, obviously over the entire face, to help extend the life of the N95 from being soiled or from being exposed. We tomorrow are moving toward what, thank you New Orleans, thank you State of New York, we are moving nationwide to the exposure and contact return to work with a surgical mask monitor for symptoms approach nationwide for our 38,000 folks. As a side interesting note, ACLS, BCLS, anything that that is a credential out there. We're starting to see more of those expire. So working with folks to figure out what to do with that has a big implication. We are working to try and establish a national EMS dedicated testing site for very targeted tests that would interface with the organization and the patient directly in an automated message of results. We are seeing an alarming increase on the non-emergency ambulance side of long-term care facilities or folks that have historically been moved at a low level BLS, non-emergency transport, that are requiring an ambulance because they may have a fever. We are providing heat maps to public health based on symptomatology so they can look in. And to, I think to John Jew's earlier discussion, we're now starting to see an increase in requests to move patients to an outpatient imaging center for CT, given its potential use in early diagnosis. And then finally, the only other two things that we struggle with right now, one is more and more hospitals are requesting, and we are denying, they're requesting that we change out of contaminated PPE into clean PPE before we can transition a patient into the hospital, both from the rotor wing side as well as the ground ambulance side, and we are refusing that for obvious reasons. And then we have just implemented yesterday, Jim, to your question, under the arch of public health disclosure, that COVID information between healthcare system providers will be shared between the healthcare system, other co-responders, including law enforcement, others that are on the scene, because of its importance in managing that. We try and include public health, but as everyone on the phone knows, it's very hard to get them involved in that. So that's kind of where we are at this point, and I appreciate all the guidance from so many folks on this call and helping us navigate some of that.
So Ed, just because I do want to switch later just to Chuck Burnell to see if anything's different with Acadian in a second. And then also I want to, just for interest, talk to Rob Holman up in Washington, D.C. in just a second. But I wanted to first ask you to answer the question we had talked about before. If you have someone's positive, what are you doing? Are you testing everybody else after that they've been exposed? Like if your personnel, if your personnel in your station or wherever is positive, how does that work?
Ed, you're asking me that question? This is Chuck, I'm sorry.
I'm asking Ed, yes, I'm asking Ed. Then I'll move on to you, Chuck, later.
Okay, thanks.
Yeah, so essentially we are, from our standpoint, no. If you are positive at a station and you've had exposure, we have an app that will roll out tomorrow. You go through the app, it registers you, it walks you through the sequence. You would then be self-monitored 14 days, development of symptoms, you raise your hand, you tap out, and then we implement testing from there.
Okay, anybody else would answer differently than that or have a different approach? And this is if someone positive in the station or in the service turns positive and you were with them, would you test the others? You're just waiting for
Hey, Paul.
Yes.
Paul, it's Miramontes.
Yes.
So I actually posted 2 PDFs on the chat about our return to work. So if we have a positive exposure, the rest of the station, it does symptom management as Ed is doing, but we do supervised test monitoring. So they have to have a temp and symptom check before assuming duty and 12 hours into their shift. That added level of protection allows us to keep those folks at work. I posted both those return to work documents on the chat. I also posted an N95 reuse infographic from our friends at USACS ER Group. Both of those information are on the chat for download.
So to throw in a little monkey wrench into it is that what defines a fever? Because some of these things are low grade and an individual may vary during the day, or you may not capture them at a point where the fever that might be undulating is showing up. Just keep that in the back of your head. I don't know if there's a solution or answer to that, but do you do multiple checks during the day is a good question, I guess.
We just sorted that out yesterday. We do 100.4 twice a day.
Okay.
Kind of a random, but we locked in.
All right, got it. So, and then how about anybody have any response to the issue of the person who may have symptoms and yet they're testing negative for COVID? Or is everybody wary of the issue about it may be a false negative?
Paul, this is John. They should stay
Yeah.
home, in my opinion.
Yeah. Okay. Got it. And
Stay-
all right.
We have them stay home, and 72 hours of symptom-free can return.
Okay, got it. And John, a lot of people have questioned that thing about the 72 hours. Where did that come from? If you want, we talked about this the other day a little bit, but can you, while we're on that point, do you mind just giving them the rationale for that?
I think the 72 hours came from the data from the swabs. There's some background going on as well, where it's thought to be 4 to 5 days of incubation and 3 days of recuperation, with approximately 1 week to 8 or 9 days where the swabs become negative. So CDC did a backwards regressive analysis, probably, as is my guess, where they assumed that the incubation period was 5 days and the time to clear was about 3 to 4 days, and they came up with a number of 7 to 8 days where they would not be infectious. I can comment on that a little bit more, but I think that's where it came from.
And then but it still begs the question of people may not be symptomatic anyways during that period, even leading into it, and they're in the station or wherever they are exposing each other. So we probably do want to do a certain amount of social distancing and maybe even masks or whatever in the work environment, I suspect. But that's just a sort of more of an opinion. Anybody have a difference of opinion on that one? If not, I'm going to move on to what I'm going to do is I want to move on to Chuck, see if there's anything, if you can do it briefly, Chuck, to add on to what we
Hey,
heard
Paul,
from.
quick comment here.
Sure.
This is Lakshmi from Atlanta.
Yeah.
So we've got multiple PRN medics that work at different services, and we
Yeah.
actually had to put out there that if you were quarantined or isolated from one service, please do not work at another service. I didn't think I needed to spell it out, but apparently I did.
Yeah, okay, good to know. And Lakshmi, I'm going to be coming back to you about dispatch stuff, by the way. So if you can hang in there, okay? Will you be all right with that?
Yeah.
Good. Okay, cool. All right, so let's know if there's anything different you have than from what you heard from Ed. And Chuck has Acadia, and so he's got a huge service across the sort of the middle southeast of the United States, Louisiana, Texas, et cetera, right?
Yeah, so we've got right now 5 employees that are positive on our list. A lot of them under investigation, and we're following the typical CDC guidelines with return to work stuff, keeping them basically quarantined the 3 days post symptoms, 7 days from onset of symptoms, full-time mask utilization. Just following that guideline, because one of the things that is also happening right now is these surge contracts and need to back up a lot of the municipal systems has got us a little bit strained, and PPE obviously is always an issue. We've got multiple sources that we're trying to get from in-state, from out-of-state, from international that have not panned out about 20% of the time, but still that's an issue. And we're looking at going to, we've bought some of the half masks, looking at reutilization of that, and some of the heat, the studies, the Stanford study on heat and whatnot, looking at redoing that, just from a PPE standpoint. And we think we're still on the uptick in a lot of our areas. Texas has been, for the most part, spared right now compared to Louisiana. Obviously, you guys know what's going on in New Orleans right now. We've been impacted heavily by that. We're also getting some, I don't know if you want to call civil unrest with some from an employee standpoint. So I'm doing daily videos every afternoon, updating on current state of affairs on PPE. On stuff like airflow and ambulances. I've got our fleet guy. We're going to do that today just to go over, ensure them that they have good airflow through there. There have been questions about HEPA filters in the units, just to make sure these people know that they are protected. Full PPE at nursing homes that are endemic, the standard things most of you guys are doing. We've been stressing the 6-foot assessment rule because too many people ending up in a contaminated environment and becoming PUIs. Full PPE for all cardiac arrests, a lot of the standard rules, but I think we're just on the uptick here. And as busy as we are, this is like a very, very long hurricane, Paul.
Yeah. All right, I'm going to move off to get some other stuff done because it's getting late in the day, but this has been really great discussion, so I want to keep pushing it. Let me just pivot a little bit over to Washington, D.C., just because there's political implications there, I think, as well. And I just wonder if you have any special things that are happening in your community by any chance, Rob, if you're still on the line. So Rob Holman, are you there? Can you hear me? Roberto. So he's on the line still. He may be off doing something else. Hey, Rob Holman, if you get a chance, pipe in, okay? So, all right. Or you may be just stuck looking for the mute issue. So then let me skip over it. Let's now move in. Hey, is there any chance that we've got either Peter Antevi or Ken Shepke on the line? I want to talk a little bit about the nursing, or even Randy Katz. Are you there by any chance? Hey, Peter, can you pipe in? Can you tell us what Randy is doing? Okay, maybe he's muted there. Yeah.
Paul, it's Craig. If I can jump in for just one
Sure.
or two items. One, I think from the National Registry standpoint, everybody's probably seen that recertification is delayed and there are provisional certifications that will be ongoing. And additionally, because of all the stay-at-home orders, Pearson View had originally shut down all of their testing centers, but we're slowly working on behalf of the registry for pre-hospital personnel and nursing students to be able to get those testing centers back up and open. It will probably be in a limited fashion, but we're trying to work on ways to support your students in the pipeline to still complete their studies and then be able to be out there in the workforce for you. So just to let you know that that's ongoing. Another issue from the federal piece, you saw the $1 trillion funding bills that have gone out, or however much it is. Please be aware that that federal legislature does not include direct monies to EMS. That most of those monies through grants and loans are going to hospital and regional healthcare systems. And so from an EMS perspective, you'll need to be aware of that. We ask you to reach out to your legislatures about that and make sure that EMS is directly included in the funding streams for future allocations that are out there, and make sure that your legislatures are aware of that. So that's a couple of items that are relatively major on the nationwide scale of things for us.
Good. Thanks for piping in. Well, I'll tell you what, since I couldn't get a hold of either Peter or Randy Katz, et cetera, to talk about the nursing home issue, and let's see and then Rob Holman's on the line unmuted, so I want to see if he can talk to us. Can you hear us now? Rob, can you hear us? Maybe there's a microphone issue on your end. Okay. Well, let's, notwithstanding that, let's then pivot into the dispatch arena and all that. Lakshmi, you've been doing a lot of work in Atlanta on that particular aspect of things. Can you fill us in what brought you to do this, your issues, and how you focused on that, and what are you doing right now?
Sure. So we actually switched on card 36 around the 13th of March, just on surveillance to kind of see what our numbers were being. And so all the sick persons, so sick person is actually our largest bucket, and all the sick person, chest pain, shortness of breath filtered into 36. And we were seeing a shift where even though our overall volumes are decreasing, the number of 36 were increasing and the number of 36As were increasing. So all the alpha calls, since we had a significant proportion of that, on the 18th, we actually moved up to a level 1. So had an alternative response strategy to the alpha calls. And we have a QRV with the supervisor or our MIH unit that goes out onto these alpha calls, assesses them, make sure they eyeball the patient, and we have a whole set of criteria that they have to meet. They should not be in a group setting or in a nursing home, and they have to be stable vital signs wise and be able to care for themselves or have somebody to care for them. And if they meet all these criteria, we were leaving them at home with a ton of CDC instructions and options for calling us back through MIH or calling us back through 911 if they should deteriorate. We've been able to mitigate a fair number of calls, and we actually QA'd all our 36 alpha calls and cross-checked with the chart to make sure they were truly alpha, that they didn't come in as alpha and then we went out there and found out they were sicker than it sounded on dispatch. And there is of course a few that end up that way, but most of them were true alphas, which is a little reassuring. I guess when our numbers go, overall our numbers are down. So we haven't had, even with our staff call out issue, we've been able to manage. But if our numbers go up and we have staffing issues, I guess we'd have to move to level 2, where we'd have to end up in a no response for the low level calls situation, which I'm not looking forward to, but that would be our next step.
Okay, fantastic. Thank you for doing that. I just want to let you know that where she's really progressing along on this, and others are following suit and working with her in different places. So, hey, Rob, I think you're trying to call in, but hey, Julian, if you can, Rob Holman's been trying to call in. Can we call him and put him on the line with us at 202-658-9158? 202-658-9158 and see if we can get him. He wants to talk about his homeless shelters there if we can get him on.
Hey,
All right. Yes.
Oh, this is Peter. Hey, I'm sorry. I've been kind of scattered and not listening too much, but I did hear Lakshmi's part. I have a little image of what we're doing in Broward County. I mean, they're way ahead of us, but I can share my screen real quick.
Yeah, I wanted you to too. I was trying to get a hold of you before, so good. Okay.
Yeah, sorry about that. It's been crazy. Okay, so basically what I'm showing you on the screen here, this is at the very top, you see our protocol 36, the Alpha Charlie Delta, and then at the very bottom, those are all complaints of the same. And you can see here, and I've been kind of learning from Lakshmi, and Stein has been really helpful to me on all this. And you can see here that we're mostly Charlie now in the P36, and that's been for the past week. You can see that even if we implemented the P36 level 1 referral for A's, for alphas, we're still getting a lot of Charlies. So I just wanted to show that. At the bottom, you can see what we're looking at for across the entire system, all complaints. So that's all. And I wanted to thank Lakshmi and Stein for really helping me on this.
Yeah, Stein, anything you have to add to it? Because you guys did want to go to Colorado Springs if you're on the line still, if you're there. Are you there by any chance? Stein?
Yeah, I'm here. Sorry, just getting off mute. I was working with Peter and some other people also come up with analysis to see what would happen if we started to go live with upper levels within the pandemic 36 protocol, and see how that related to all calls and how that was going to shunt our resources. And so we're discovering the same thing as Peter just mentioned there. And we're trying to keep tabs on that to figure out not only how, as we move up levels, we're going to alter our response within the pandemic protocol, but also how that is going to potentially shift certain determinants that responses that don't fall within the 36 protocol.
Okay, thank you so much. I'm going to switch gears really briefly here to go over to Randy Katz, who's got Hollywood, Florida. And when Peter got on, it reminded me that there are some interesting aspects that about nursing homes and maybe whatever, maybe a la New York City or other places are a very common problem in Florida, high rises where people are bunched together, condos particularly. So Randy, tell us a little bit about the initiatives you're doing with respect to nursing homes, and that's a big problem in the South Florida area where you're from, Hollywood, Florida.
Yeah, so just in my city alone, we're a city of a couple 100,000 people, and we've got 16 nursing homes in our city alone.
You put your mask on. You're very close to us. All right, go ahead. Sorry, go ahead, Randy.
So we just in our city alone, we have 16 nursing homes. In Broward County, there's probably close to 100. I've been surveilling. Our hospital is the only hospital in our county that does in-house testing, and we have turnaround times sometimes as short as 12 hours. So I've been surveilling all of the results and identified early on some transport trends, and was able to identify a nursing home that has 218 residents that are all fairly sick, older patients. These are not ALFs. I mean, this is like a skilled nursing facility with over 200 patients, and identified one patient transported on Wednesday, and then immediately the following day, another patient transported. I just decided to go over there with a team of our nurses, and Chief DiBernardo was there. He happened to be there bringing some PPE because they didn't have appropriate PPE. They didn't have any of the equipment they were supposed to be using. And subsequently, as of today, I've now tested the nurse that took care of those patients who's positive, and then another patient who was the roommate that had diarrhea yesterday who's now positive. And so we now have a cluster of 4 patients there. And so what we've done is basically gone through their list of every staff member who's worked with those patients in direct contact. And we're going to actually test every single one of them, whether they're symptomatic or asymptomatic. Because the last thing that we need, at least here in South Florida, is, a couple of nursing homes with a few hundred patients to go down. And that, would absolutely stress not just the EMS system, but the whole hospital system. So I guess the message is, if you do live in a cluster of, a dense area with nursing homes, somebody needs to be, closely tracking those places. And as soon as you identify 1 or 2 patients, you got to get in there quick and isolate and quarantine these people. Because this is the population that's most susceptible, and this is going to create a major issue for the healthcare systems and EMS.
Yeah. Thank you for that alert. I think most of us kind of sort of in the back of our heads knew that, but it's really great that you're taking specific steps. And by the way, before Randy, I did mention that that's like what I heard in Melbourne last night, Melbourne, Australia, and other places, that you were one of the first people to alert us that you were seeing a lull in EMS calls and the emergency department, that all of a sudden now it's picking up to more acute cases than you've ever had before. Is that the trending still, and are you worried about it getting worse?
Yeah, I mean, just as Peter showed, they're Charlie calls. These, most of the patients coming in by EMS are hypoxic or, lethargic, from nursing homes. We've had, I'd say, probably at least 15, 20 positive EMS transports in the past week, whereas the volume last week early on was ambulatory volume, just walking into the ER to get tested, or, complaining of cough.
Yeah.
And so you can see the transition into EMS now, and the patients are sicker that are coming in.
All right, and then I don't know if Ken Shepke's on the line or not, but that sort of transitions into something else that he brought up, which was the issue about a lot of the condos, especially with elderly people down in your neck of the woods, and I'm sure that's the same in New York and various other places. Some places have established very good rules in their areas, and others have not, and that could be another source, along those lines, analogous to the nursing home issue. All right, let me move on now to, we ever got Rob on the line by any chance? Rob Holman from Washington, D.C. Did ever?
Hey there, Dr. Pepe. He put me on hold, but looks like I'm getting it worked on.
Okay, that's fine. We're all busy, and these are longer than I thought, etc. One thing I would like to bring up real quickly before we all get off the line is the issue.
Hey, Dr. Pepe.
Yeah.
I'm really sorry to interrupt, but if you give me like 10 seconds, I can merge the calls and you'll be ready to go.
Okay, fine. Well, I'll give you 10 seconds then. How's that?
Fine.
In the interim, I just sort of give it for those of you who are getting burned out in this call. Okay. So, Rob, are you on?
Can you hear me now?
Yeah, go ahead.
I think I am.
Yeah, Washington.
Oh, perfect. Thanks.
On in. Tell me about what's happening in that land of 70 square miles surrounded by reality. Okay.
Oh God, I know. So we're not as developed as some of the big cities. We only have about 237 cases now. We do have 12 members who are infected. We have about 15 whose tests are pending. We have about 130 on quarantine. We are currently using a test-based return to work policy that may change. I think what's different about us is we've got the largest homeless shelter in the country with 1,500 beds, as well as many other large-size shelters. The shelters have done symptom and temperature screenings with a temp cutoff of 100 degrees since last Monday, so for about 11 days. And shortly thereafter, we finally had a homeless COVID-19 set of hotels open up. There are only about 15 people living in them right now. We think that's probably the most important thing that we've done. And we also have a case in the jail, and that's where we are.
Okay, got it.
Yeah.
All right. And then is there any, I don't know, just because you are the nation's capital and all the politics, anything out of that end that, that you're sensing, or something you can't talk about really?
So a couple of things. We have adequate PPE, and I'm sure that's because we're Washington, D.C. So that's probably the only unique thing. We're not involved in For example, the Senate, where they've had cases, we're not involved in the House of Representatives. That's separate. Interestingly enough, our first case was an Episcopal priest. Our first death was a Catholic priest. There's another priest, a Catholic priest, who was among our 75 cases. So I think the whole guidelines about restrictions of religious congregations gathering is something I would make sure everybody's municipalities and jurisdictions is looking at.
Okay, that's fantastic. I'm glad you were able to finally get you piped in. We got to figure that out in the future, so we get to hear from you.
Yeah.
I wanted to.
Thank you.
Some of the things that I want to talk about, before we finish up, is just quickly will be on some of the issues of like the pending things about antibodies. And Paul Adams, are you on the phone by any chance? What we may look at is antibody testing. If not, Peter, are you there? Can you address that real quickly?
Yeah. So the antibody testing is the one-drop blood test. There's many different manufacturers, probably about 10 now in China that are being manufactured. They have the FDA emergency waiver. Essentially, what it does is that with one drop of blood in a reagent, it shows you the control, it shows you it shows you a IgG and an IgM, or it shows you nothing. And so there are different reports for these specificity sensitivity reports. And so we're looking into that now. And the utility that we see it is that if someone has IgG only, then that means they've already passed the disease and they have some sort of immunity to it. IgM means active disease. And then if there's no IgG or IgM, it means they've never been exposed and they should kind of move with caution. And the reason we're even looking into these is because in order for us to get our folks back to work, we've developed a return to work policy, and the fire chiefs want a test-based policy. Problem is we're getting our test results, unless you go to Randy's shop in Memorial, where he can get them back for us within a day. Everybody else is getting results back in 5 to 7 days. And the fire chiefs want 2 negative results before they can go back to work. And so there's no way we can do that. So we're trying to look at alternative mechanisms to get that done.
And who'd want to torture your people with the brain biopsies as well? But Peter, when does from my understanding, this thing is pretty much close to 100% specific, but maybe only 90% sensitive. And one of the reasons might be if you test too early. How long is it? Is it from the time of onset of the exposure or time of onset of the symptoms that 4 or 5 days later, the IgM starts coming out?
Yeah, I would say, safely you could say 7 days. Some people are saying 5 days. But I think we're going to try to use it for like return to work issue and not really, I think that when someone has symptoms and they're actively ill, then we'll maybe wait a couple of days to test them. Hopefully with your brain power, perhaps we could do, we can actually look at the data on this as we move forward. And that's where your wealth of knowledge would come in for us. We'd be grateful for that.
Yeah.
But we have significant requests for it here, and we're going to move forward with it. And our first ship is coming in on next Friday.
All right. Well, the only thing I'll leave with is that we got to absolutely study it and maybe look at prodrome symptoms first, as well as the typical or even asymptomatic, how many people are asymptomatic, et cetera, and may turn positive. So we'll see. Next question I wanted to run it, just as this is maybe I'll quickly just make a point of information, as some people are looking for places to set up makeshift ICUs, or I should say secondary backup. Places like sports stadiums or arenas are actually sport arenas. There's they're closed roof, but they have showers, air conditioning, and they have lots of toilets, etc. Have been proposed as places, and also these surgery centers, and sometimes maybe these unvisited urgent care centers. It depends. But let's just I want everybody to get creative and think about that. Before we depart, I saw Katie was on the phone, Tataris from Chicago, and you guys have been largely ignored by the media, but I think you're getting hit hard. And so also Ron, if Rob Dunn is there from Detroit, I wanted to hear from him. But Katie, are you still there?
Yeah, I'm here, Paul.
Yeah, tell us, is there any perspectives or anything new you can add to the picture here from your end, from Chicago?
I think we're seeing what everyone else has described, kind of a low call volume by EMS and hospitals ramping up in terms of surge capacities. I mean, each hospital is putting up tents outside and looking at COVID cohorted units and then transferring out kind of these vulnerable populations like skilled nursing facilities, trying to put them somewhere besides just the acute care hospital. So we're looking at turning the United Center into a kind of field hospital. So all the wheels are turning and we're trying to keep up with everything as it's moving at the speed of light. Absolutely. Good plan. That went along with what I just said. So thanks for helping to reaffirm that. Okay, well, good. That's terrific. I just want to know, is there anybody else on the phone from either over in Europe or overseas? And then I saw another call from area code 202. Do we have any federal partners on the line that we can pipe in? And if not, I think we're pretty much getting close to Erica. Well, I saw you on the line very nicely. You want to pipe in and tell us what's happening in Kansas City? Any perspectives there?
I would like to comment on the messaging of the positive firefighters. So we have about 1,400 employees with our first positive firefighter a couple of days ago, and the messaging yesterday did not go well. So just like was mentioned earlier, firefighters are very interested in exactly who it is, where they were, who they were working with, and just like Augustine had mentioned, the IAFF and the IAFC have their messaging as well. So I've actually found really good support from our union partners in this right now and from fire admin. And so the messaging came out from all three, fire chief, the unions, and with the support of IAFF. So even despite that, I think the firefighters are very scared right now. And so no matter how the messaging goes out, I think you're going to see a response of fear. So we had people demanding to know who it was and where he was and where he had worked. So what we found worked best with the firefighters was we just talked about a general region, because we're broken down into battalions. So we said in the North region, and then we set up messaging. If you have concerns that you don't feel were addressed, contact this individual directly. And once we set up that pathway for direct messaging, it really diluted the fears down a whole lot, and they could speak to fire admin directly. So I think a cache or a place where concerned employees can automatically address their questions and fears. We have that in our, what we call an intranet. So they literally just type in their information and it shoots an email out to the union, myself, fire admin, including fire chief, and then we can respond within seconds. So I wish we would have had that up and running before the messaging, but it came out of the messaging and it actually subdued a whole lot of fear.
Okay, thank you, man. And there's a couple other people I thought I'd have pipe in, if you don't mind, before I wrap this up. Tom, anything new out of Cleveland? If you're available to talk to us, Tom Collins.
Sure. Yeah, things are starting to pop up here. We've had a couple of our EMS providers test positive, despite knowing they were caring for a positive patient and being in exquisite PPE and following proper donning and doffing procedures. So that's a little unsettling to the crews that despite all the guidance we give them, they're still at risk for getting positive. And
Right.
we had the same issue with the fact that they're stationed with our partners in the fire service. And so we had all the three unions that are involved in this clamoring all over each other, trying to get messaging out to people, and it created some difficulties.
So the other thing is that they may not be expressing it, or they may, far as I know, is that there's the issues that people are not only worrying about themselves, perhaps, but also bringing it home to family and loved ones and kids and all that. Is that a strong issue there as well, I assume?
Yes, and we've been encouraging people to bring a change of clothes to change into before they go home and launder their clothes at work.
Yeah, and I was hearing that some communities are actually setting up hotels for the first responders to go to in this interim, so they don't bring it home. And that's been an interesting thing because the hotels are all empty too, and that would make sense. All right. Trying to think of that. Let's see who else I got on the line. Megan, by any chance, and you're up in Madison, Wisconsin. If you're on the line, is there anything new to add from your end yet? I don't know if you heard me or not. Megan Gussick, are you? Yeah, I hear you. Go ahead.
Good morning. We're still kind of in the quiet before the storm phase. We have had 3 of our Madison fire, actually mostly chiefs, of which I spent a significant amount of time with over the past couple weeks, test positive. But our actual core field staff are somewhat COVID-free at this point, but we're just starting to see the numbers ramp up. So just kind of preparing from that standpoint. But otherwise, same struggles as everyone else.
Yeah, okay. And then moving quickly, I'm going to go to Jeff Goodlow in a second, but moving quickly back, I saw Chris Richards is online. Chris, anything else you have to add as far as the, you know, what do you call it, the Chicago scene goes?
Yeah, and actually, I just very recently joined the group here out of Cincinnati in Southwest Ohio, and so we, you know, are addressing a lot of the same concerns that everyone is in terms of PPE, which calls to put PPE on, and then especially the time off work. So this is very helpful. We've also, you know, we cover a little bit into kind of some rural areas, and so we've started to work a little bit with health commissioners to get maybe some pre-notification, some information on which addresses in the community have actually tested positive already. And so we're starting to kind of see how we can work that in.
All right, thank you. And then Jeff Goodlow, you're usually ahead of the curve. How about this time? Where are you on this, and anything new that you can report to us or perspectives out of Tulsa and Oklahoma City? Besides the fact that you have a lot of empty American Airlines plane there on the tarmac.
Yeah, so we are trying to stay with the curve. I don't know if any of us are ahead of it, but one of the key things we've been doing, recognizing the baseline unhealthy populace we have, a lot of folks in nursing homes, long-term community housing, maybe for some a surprising amount of homelessness in both of our cities. We have put out directives that we want those folks brought to entry-exit points when EMS is being requested. We understand that there will be certain circumstances, active seizures, falls with suspected pelvic or hip fractures, certainly cardiac arrest, those type of things where the patient could understandably not be physically moved. But otherwise, we want those folks at or even outside the entry-exit doors to reduce the potential cross-contamination with our folks. You know, as you might imagine, with between the two major cities, you know, a few hundred or so recipients of that information, we're getting a spectrum of responsiveness, but we are moving the ask to an expectation here in this next week. We do not want to send our folks into these facilities unless absolutely mandatory.
All right, thanks.
Hey,
Chris,
can we
go ahead.
go back to Jeff for a second? Jeff,
Yeah.
I think from media reports, your fire agencies are using SCBA for patient contact. Any thoughts or comments that you'd be willing to share with the group on that?
Nope, but thanks for asking.
Yeah, got it. Thanks.
We just found that out this morning.
Oh, cool. Well, listen, let me just then pivot real quick a little further south down to Houston. Chris, anything to add to the conversation from your end in Houston, since you got the fourth largest city?
Okay, we only have 68 cases locally, one firefighter positive, about 73 on quarantine due to meeting medium and high risk criteria. We actually are getting a bunch of PPE in today, so we seem to be okay at the moment. Sorry to gloat.
Yeah, okay. Yeah, don't gloat too long, right?
Yeah.
Okay. Bro, good to know. And then let me just check in with Milwaukee. Are you there by any chance, Ben? Or can you tell us a little what's happening in your city?
Yeah, sure. Hey, everyone. So one of the biggest issues, we're certainly dealing with PPE issues, trying to figure out what the guidelines are beyond the CDC, what to start recommending. Some of the comments have been really helpful for that. One of the biggest issues we're seeing is we have the honor of being the most segregated community in the country, and because of that, that population is getting hit particularly hard. We have one of the highest rates in our Central City African American community, so we're working hard on messaging there. From an EMS perspective, I'd be happy to send it out actually, sorry I haven't had a chance to yet, but we have United Guidelines. We have 15 different fire departments. They're all working together, which is a miracle in and of itself, doing co-staffing, special COVID med units and alternative vehicle responses and stay-at-home orders or stay-at-home recommendations. So things are moving along. Thanks for the opportunity.
Oh, no. Okay. And there's probably other people on the line that I can't tell from their phone numbers. I have a 202 area code here. I've got a 505. And is that Kim? Are you there, Kim? Okay. If it's not Kim Pruitt, I just wanted to see. I just some of these numbers I can't identify, so I don't know how to call on them. So I wish I could. So, and Chris Kahn, anything you have to add from the San Diego area beyond what Joel said?
Good morning, you guys. Sorry, doing 3 calls here. No, we are pretty much as Joel said. Things are starting to ramp up a bit. We've seen more positives within our services, including within one of our lifeguard academies. One of the main fights that we're working on right now is just keeping unified messaging and making sure that when we provide occupational guidance that people actually believe us. So it's been really important to bring all the other groups into the fold when we deliver a message.
Okay, thank you then. And then I saw a 651 number. So is that possibly St. Paul or Minneapolis, or can anybody there pipe in, whoever it is from that neck of the woods? Okay, if not, then I'll move on. I think at this point, let me just turn it back to some of our key players on this over the past little while. John, anything new we could add to this, or can we talk next time a little bit about infectivity and testing and so on?
Yeah, I just wanted to say on all the things, number one, there is a substantial amount of the minority who are either mildly symptomatic or asymptomatic. And Mike Sayer on a previous call documented that the crews were only able to identify 75%. So if you don't mask up and have core basic PPE on all calls, your crews will get sick, period.
And I think that people should be more sensitive to the atypical, if you want to call them that, maybe they are typical, issues like the diarrhea or like the anosmia or like the silent hypoxemia, et cetera. And those may be ways to screen in a little bit more. But that's part of the reason why I put that out today, so that people were sensitive to that. Okay, well, that's great. We'll talk more then, John, on that next time around. And then Jim, Augustine, anything new again from your end, or anything you want to do on the wrap before I go to Craig?
Nothing. Thank you. Thanks to everybody for responding on all these surveys. And I'm trying to minimize traffic, but it's hard. Thanks, Paul.
Okay, good. All right. And then, yeah, go ahead.
This is Stein Bronsky. I just wanted to let everybody know that I'm finishing up getting all of the non-transport protocols in line so that I can send it out in one document to everybody because they're hard to keep track of as they've come in.
Yeah. It might be nice to, I don't know if you got someone who could do the work because you're busy, but to take those and actually see if there are common elements that would make us more of a standardized protocol, and then some variations on those themes, et cetera. I don't know if that's a lot too much work to do, but it'd be kind of fun, if that was feasible, just it would help a lot, in terms of tightening it up, and also give us something we can put out as a publication or not, or at least as a monograph amongst our people. So, okay.
We've done a comparison of all the ones that were submitted and have some notes for you, Stein.
Okay, good. Hey, Chris Zuber, and I didn't mean to totally leave you out. Just anything else to add from what we talked to you before about? By any chance, you or Alexa have anything to say at this point?
No, I think we're just dealing with the same issues that everyone else is.
Okay.
The usual stuff. Nothing otherwise.
Okay, great. So nothing new related. I was actually a little surprised to hear that. That I thought with all the tourists that come in there from other countries that you were going to have bigger problems, as we talked about last time. Okay, and then Craig, let me go back to you. First of all, before I go to Craig and to wrap this up, and I have to thank him and Julian again and his chiefs for making this all feasible and helpful, especially his time. And this is very appreciated, and it makes a big difference. And especially his board members and all that have approved this. I just think it's just fantastic. But is everybody okay with the format? It's awfully long, but for me, it's been really worth it. So I just want to know if we want to keep going Tuesday and Fridays with this. And I'll try to cut it down a little shorter maybe, but this was a good, get a lot of stuff out of the way day. Anybody have any objections or suggestions, please let me know. I'm trying to do what serves you best, okay? Craig?
Great. Thanks again, everyone. Appreciate you joining on. We would love to have feedback on how we can improve the communications for you. Julian has one good news story regarding PPE that he'll share with you here for just a quick second thing. So Julian, feel free, go ahead and let them know what you were able to make happen on PPE.
Yeah, I was sent to the contact information of someone who works for a company called A&P Distributors. Never heard of them before. The person is based out of Austin, who told me that they had several thousands of N95 masks in the warehouse ready to be shipped. I was a little sketchy at first, but I went ahead and placed the order. We placed an order for 1,000 of them. And we placed that order on the 20th, and we got them yesterday, just 6 days after. Now, they are the KN95s. It's the Chinese standard equivalent. But I did, and I'll pull it up on the screen very briefly, I did get a document that was published by 3M earlier this year. And the summary of this document, it says, based off this comparison, the international standards are equivalent to the US NIOSH N95 standard. So we have 1,000 N95 masks that we order and got them in 6 days that work well for our crews.
Great. Thanks, Julian. And so just, again, some alternatives to be able to look out there to help solve all of these creative things of doing your own mask and whatever other options are available for you. The other piece is Julian had a little bad news story, and it kind of reflects on maybe some of the things to come. We heard some civil unrest comments out there. Julian had his marked response vehicle broken into last night and had all of his computers stolen. His chief thinks he really just took him to the pawn shop. But, again, some of those things are happening in your communities with increased activities like that. So just be aware of it and be sensitive to it. And with that, I think we'll close today. Julian's going to get the recording processed and hopefully posted in short order. It takes a little bit of time to do that, but we'll have it up on the website to share for other folks as well.
And Craig, a quick question. There's the sidebars turned out to be really good. I'm glad everybody did it, and I try to use some of that stuff for the conversation, but it's a little bit hard to keep up and multitask for me. But it just, like, for example, Libby just piped in and said she called an AP distributor guy in Hawaii. They have 33M green bubble type masks for whatever, $675 each. And we have offers for KN95 about what is that, $350 each? You said, sorry, $3.50 each. Okay. So these comments are out there in the right that I have. I just read that now, but those comments, can they be kept, or there's some way to have those archived?
I don't know, Julian, are they able to be captured?
Yes, they can. I will post it below where the video will be posted on the website.
Yeah, because I couldn't totally keep up with those, but there's some good comments there, so that'd be good. Okay. Anybody else want anything else before we get off and I adjourn this meeting and see you next Tuesday? Anybody else want to pipe in on anything we need to know? If not, I hope go ahead. Yes.
So I have a cousin in Israel who's pretty high up in the government, and he called me yesterday and he says he's looking for ventilators. So apparently the Israelis are having the same issue and they're looking to China for ventilators. So I have a sense that we're going to be in trouble here in South Florida, but I'm just wondering, is anyone on the call in trouble yet besides maybe Glenn up in New York?
Well, the answer is not yet, right? So yeah, so that's something. And then the other thing is I'm going to explore is this whole issue about those helmets, the CPAP helmets that have been very useful in Italy for a lot of reasons. And so I've been talking to the critical care guys about that stuff. So I'll get back. All right, if there's nothing else, then let's go ahead and adjourn. This has been a long enough meeting too, and for me, but absolutely worthwhile for me. I don't, I assume for everybody else. So thank you so much, and thanks for everybody else for all the contributions made today. I'm really glad today because we had a lot more participation, and that was very nice to hear from everyone. So thanks again. All right.
Thanks for all your leadership, Paul. Appreciate you. Thank you.
Okay, Craig, ready to zoom off?
We're good. Take care. Thanks, everybody.
All right. Good afternoon and good morning to others. See ya. Bye-bye.